My name is John de Caestecker. I'm a gastroenterologist at University Hospitals of Leicester in England, United Kingdom. I'd like to talk to you on behalf of my co-authors about the Barrett study being published in Gastrointestinal and Endoscopy. The title of the paper is Radiofrequency Ablation, RFA, compared with argon plasma coagulation, APC, after endoscopic resection for high-grade dysplasia or T1 cancer in Barrett's esophagus, a randomized pilot study. This was carried out at 6 English regional upper GI cancer centres by endoscopists experienced in endoscopic management of esophageal early neoplasia. It was a 3-year study funded by the UK National Institutes for Health Research under their Research for Patient Benefit programme. The NIHR have asked me to add the disclaimer that our views are not necessarily those of the NHS, nor the National Health Service, nor the English Department of Health. Firstly, why do the study? Endoscopic management has largely replaced surgery as the treatment of choice for high-grade dysplasia and T1 cancers arising in Barrett's esophagus. The main intervention is endoscopic resection, both for accurate staging and definitive treatment. But we know that up to 30% of patients will have a metachronous neoplastic lesion, mostly in the first 2 years of follow-up. Therefore, ablative techniques have been developed to eradicate the remaining Barretts. A recent randomized control trial of APC after endoscopic resection done in Germany and published in 2014, the APE study, showed proof of concept by demonstrating a 10-fold reduction in metachronous neoplasia in those treated with APC as compared to surveillance. The best researched ablative technique is, however, RFA, with a standardized methodology allowing a predictable burn depth. Randomized trials, meticulous cohort studies, and extensive registry data from the US and the UK have shown RFA to be both safe and effective. Our aim was to compare APC, a less studied and more operator-dependent technique, with RFA in a randomized pilot study. The primary aims were to assess recruitment over 1 year, retention in the trial over a further year, and clearance of high-grade dysplasia or cancer 12 months after starting treatment. Secondary aims included clearance of Barrett's at 1 year, quality of life, complications, and cost economics, for which we employed a health economist. Our results. We screened 171 patients, 107 of which were eligible, and 76 agreed to enter the study. 65 completed the study. All participants had to have had endoscopic resection either at enrolment or within the previous 6 months, with histology of the endoscopic resection specimen confirming high-grade dysplasia or T1 cancer not exceeding M3 invasion depth. They were then randomized to receive up to 4 treatments every 2 months with either RFA or APC, thus over a total 8-month period, allowing endoscopic resection at any treatment session if further visible lesions were identified. The trial ended with an endoscopic assessment and biopsies at 12 months after enrolment. A quarter of the patients had T1 cancers and the remainder high-grade dysplasia. Approximately 35% had Barrett segments less than 5 cm in length, 60% 5 to 10 cm, and 5% greater than 10 cm. Retention was 77% for the APC arm and 94% for RFA. The reasons for dropout are presented in the paper. At 12 months, clearance of dysplasia or cancer was similar at 80 to 84%, improving to 88 to 94% at 2 years. Barrett's clearance, defined as no visible Barrett's and no intestinal metaplasia on histology, was 48 to 55%. Buried glands were found in 6% of RFA treated compared to 13% of APC treated individuals. Quality of life, measured by the generic Cancer Quality of Life Questionnaire QLQ30 and by the esophageal specific instrument OES18, was similar, as were side effects, in particular stricture 8% with either technique. However, cost was approximately 6 times more for RFA. The limitations of the study include the fact that we limited the intervention opportunities in the trial to 4, so Barrett's clearance was less than in some published registry data and careful cohort studies, but nearly all the patients continued endoscopic treatment after the trial ended, so we would expect the Barrett's clearance to have been better with more treatments, but we have not collected this data. I hope you'll read the paper, which provides more detailed discussion and critical comparison with published data. It's also worth pointing out that we only included in our study patients who had a visible lesion requiring endoscopic resection, not patients with flat invisible dysplasia. What does this data add to existing knowledge, and what next? This is the first trial to directly compare RFA with APC in the management of dysplastic Barrett's in a randomized environment. It was not powered to detect a difference, but the results appear similar with both ablation techniques, apart from a significant difference in cost. If there's truly no difference in efficacy, safety or acceptability between the two techniques, cost implications for increasingly cash-constrained health economies are worth considering, but this would need confirmation in a fully powered non-inferiority trial. We have suggested in the discussion section of our paper some ideas for maximising recruitment to such a study by widening the inclusion criteria. Thank you for listening, and I hope you will be motivated to follow up by reading the full paper.